thing so far. Let's jump right in. Today, we're talking about how we are treating rheumatoid arthritis, what's the goal of treatment, as well as how we are getting to the goal of treatment. So the first thing is, so we've talked about what rheumatoid arthritis, we talked about how we diagnose rheumatoid arthritis, and the third version today is about, how we treat. First thing is to realize that in rheumatoid arthritis, our goal is full remission. I repeat, in rheumatoid arthritis, our goal is full remission. Now, remission is not the same thing than cured. Remission is basically you have no more pain, no more symptoms, no more joint pain, no more joint swelling, no more morning stiffness, and you're doing really well. And you don't remember you have your rheumatoid arthritis, except for the fact that you may need one treatment or two treatment or whatever, you need treatment. But that's the only time you remember that you have rheumatoid arthritis, is when you're needing treatment. So that's what we call treat to target. And that's a scientific term when we're looking at studies. The treat to target, the target is full remission or minimal disease activity. When we say minimal disease activity, we're talking about you have the right, you have the right of everything. But basically, we should not be happy if you have more than one joint that's painful or tender or swollen. So, okay, this is important. Our goal in rheumatoid arthritis is remission, so no symptom whatsoever, or you have the possibility of having one joint that's painful or tender or swollen. Okay. So now imagine that that's where we're going, right? So this is where you are. So if you're there, probably you don't really need me to see, like to discuss more things with you, but this is without prednisone. And the reason I say this is that I can get there with prednisone, steroids. The problem is steroids has so much side effect that that's not an all in all, right? So you want to achieve this without steroids. Okay, now, how do we get there? So that's the called treat to target. There were studies in the past where we looked at a stepwise approach. We try something, doesn't work. We try something stronger, doesn't work. We try something stronger, doesn't work. We try something stronger. Or, and if you want to look at the study, it's a SMART study, S-M-A-R-T, at least 20 years old. And there were many others that proved that. But the first one, I think one of the biggest one was the SMART study, showed that if you actually try to reach the remission, reach the target faster, you have more chance of getting the patient to full remission. And because you have more chance of putting the patient in full remission, then you can back off of treatment. And so our goal at first, when we have patients who have rheumatoid arthritis, is to, one, we make the diagnosis, and then we are going to treat, and we're going to basically get to remission as fast as possible. So you will hear me sometimes talk about early rheumatoid arthritis. That's rheumatoid arthritis with symptoms that have started only in the past 3 to 6 months. We know that we have a window of opportunity to put our patient in full remission if we treat them in the first 6 months aggressively. What I mean by that is that you could say, okay, I'm going to try first hydroxychloroquine, and that is a non-immunosuppressive agent. Totally fair. But it takes 4 months sometimes to work. And then if you take 4 months then to realize that it doesn't work, then you're going to, maybe add methotrexate. Same thing. You're going to maybe take 3 months to see if it's working. And then you're going to say, well, it's not working. Then I'm finally adding another medication. So maybe like sulfasalazine. But then it's going to take another 3 months to work maybe, right? And so then you've lost 9 months. So now what we are thinking in terms of treatment is that we are trying to get to the remission part as fast as possible. And so the recommended treatment right now is to start with methotrexate. The insurance will make us start with methotrexate. And then if that doesn't work at 3 months, we go to a biologic. So I repeat, if that's not working at 3 months, we go to a biologic. So technically, you're only losing 3 months if that doesn't work. I would say that sometimes we don't have to do methotrexate if you don't tolerate it. And then there are some patients where if it's very aggressive, we may want to do more than just methotrexate. So in Europe, for example, they start methotrexate and plaquenil almost in everyone together because there is a synergistic action together. Okay, so we start, let's say we are going to go with what insurance wants, methotrexate. You may, if it's aggressive, take methotrexate plus plaquenil, and then you adjust at 3 months. At 3 months, if you're not in full control, you add a biologic. Usually, we're recommending TNF inhibitor in the vast majority of time because they are historically the ones that have been there the longest. And we actually think that they are also very good for the heart of patients with rheumatoid arthritis, the vessel, and so on. So we take a first TNF inhibitor. Then we readjust. At 3 months, are you in full remission? Yes, continue. No, then we switch. And this is where I disagree with insurance. Some insurance will ask us to try another TNF inhibitor. I think it's wrong because there are studies that are showing that 2/3 of patients who don't respond to a TNF inhibitor will not respond to a second TNF inhibitor. Some patients do, so that's fine, but I think it's a loss of time for our patients with rheumatoid arthritis. So methotrexate, vast majority of time, first line, second TNF inhibitor. At 3 months, if that doesn't work, you switch to another biologic agent. There are so many agents. I would say in general, you may be afraid of a biologic. They have been there now for more than 20 years. So I really feel extremely safe. I've never really seen any complications from them. I see complications from, methotrexate. I don't really see much complication with biologic. It does happen. You may be allergic. Maybe you don't like the injection and so on. But in general, they are very safe. I'm going to go again, in terms of this, because I really wanted to realize this. We have so many treatments in rheumatoid arthritis that we are cycling fast. 3 months is probably the usual time. And the reason it was chosen is twofold. Number one, it leaves enough time for the mechanism of action of our drugs to work. But very often, it's also because in the vast majority of practice, rheumatologists don't have enough time, enough spots to actually see patients faster. So that's something that we can work on this if you have a rheumatologist that can see you a little bit more often. For example, the methotrexate, you can increase the dose every month. And then you can switch. If you see that there is no effect whatsoever, at 2 months, you may already start the process of the prior authorization before the 3rd month. Because again, sometimes it takes 2 weeks, 3 weeks, 4 weeks for the prior authorization to be approved, to go through. So again, goal is full remission. How do we achieve it? But by doing an immunomodulation of your immune system, getting back to a full balance. Once you have full remission, no more joint pain, no more swelling, no more pain, then that's when you can start thinking, okay, I'm maybe able to back off. I've seen patients where you can actually see that they don't need as much medication. And so we're seeing, hi, Keith, sorry, I'll respond to you. Hi, Keith. So we will see that, if you are in full remission, we may, wait a full year and then you back off of the medication. But the first and most important thing is to get you to full remission. And while steroids, so the prednisone may work at first, and, it's actually not a bad drug. That's not a problem, right? But you just don't want to be on it forever. So it is actually considered a DMARD. It decreases the risk of erosion. So that's good. The issue is that it causes all those other complications, infection, diabetes, osteoporosis, and so on. So you don't want that prednisone. But you could start with a little bit of steroids with the knowledge that you need to be out as soon as possible from it because you don't want it. And then you also then move on to the other medications. And if you're not afraid of prednisone, then that's a problem because you should be. I am. I love and hate prednisone at the same time. I love the other drugs. I love my biologics. I think that are wonderful. And in general, I think that in rheumatoid arthritis, we are extremely lucky I mean, it's really cool when I can say, yes, we can reach remission, because that is the truth. We can reach remission. We have incredible amount of medications, and they are really safe. And I'm happy to explain how they work each, if one day you guys are interested. Okay, I think that I've, talked about what our goal is for rheumatoid arthritis treatment. I really go back to try to treat as early as possible, and you have to be aggressive at first. It's like a fire. Yeah, if there's a fire, you don't want to just put a pipette of water. You put a bucket of water, then you back off. All right. So we have some questions. I'm really excited. So what you're saying seems to apply pretty well to autoimmune disease. I have systemic vasculitis. How much overlap is there? Yeah, absolutely. So rheumatoid arthritis is really cool because we have so much studies. And the reason why we have so much studies is that it's the most common autoimmune disorder out there in rheumatology. And so we have a lot of, it's the market share, right? Like the drug companies are very invested in trying to make as much money as possible. So you're not going to take the rare disease because then there's not that many patients to treat. You're going to take the disease where there's a lot of patients to treat. The cool thing, though, is that from rheumatoid arthritis, you can learn a lot from other conditions, including vasculitis. So first of all, rheumatoid arthritis can cause vasculitis. So that's like number one. But second of all, when you're thinking of how rheumatoid arthritis works, you're like, yeah, it does work also for vasculitis. The difference with vasculitis is that some of the biologics don't work. So for example, in vasculitis, if you have ANCA vasculitis, TNF inhibitor does not work. Whereas B cell depletion will work. And that is really something that can actually help. So in general, for vasculitis, I would say, just since we are here, you're going to try to treat early aggressively, and then you're going to back off. If it's ANCA vasculitis, I do not know what you have, and this is not medical advice always, but if you have ANCA vasculitis, and it's not like, I personally don't go around the bush. I mean, we have Rituxan now, it's CD20 inhibitor. We know how it works. We know it's been there forever. And then really, I've never really seen much complication from it. And so basically you take Rituxan and then you back off. And then you have, maybe at first you've had 2 grams every 6 months, but then later on you have 500. So half a gram every 6 months or 4 months. And depending on how you're doing, you can actually push that a little bit further. So to me, that's why I feel like there's no point of turning around and saying, oh, I'm going to try a little bit of azathioprine, I'm going to try a little bit of methotrexate, when we have incredible treatment. If you have a vasculitis that affects that has affected your kidneys or your lungs or whatever or whatnot, or your nerve, to me, I mean, I just don't think it's worth waiting. But it's some discussion that can be done with the patients, as you get to know them as well, and what's the fear and so on. I would say in general, there are some drugs where patients may think that, oh, this is a really severe drug, it's much stronger, but really they have less complication than other. In general, the truth is that the science has been really incredible in immunological disorder. And I find that the biologics are way more the tolerance of the biologic is so much better. It's just, it's just targeted. You're treating exactly this one cytokine or this one cell, this one receptor. And to me, that's why I feel very good about this, because then you also you're switching off a signal that's really helping you get to full remission. And so in the case of rheumatoid arthritis, we're going to try to turn off either the TNF, because we know that's very pro-inflammatory, IL-1, IL-6, same thing, very pro-inflammatory. You're trying to turn that off. In vasculitis, you're trying to turn off the B cells that are making antibodies, such as ANCA. And the truth is that Rituxan also works really well for rheumatoid arthritis, especially if they are seropositive. It's just that we have other options at first that we can try. But I love Rituxan in some cases in patients with RA. So yeah, I think that was a really, really good question. But in general, yeah, you're thinking of treat to target can actually apply also for psoriatic arthritis, for vasculitis, for a lot of autoimmune disorder. but yeah, I think that that's concluding our Room 101. I'm trying to make sure. I don't know that the live on Instagram went through. I'm not sure. If you have any question anyway, you can always put them in the comment box. I'll be happy to answer them as the week goes. And then next week, I want to talk to you about ANA, what ANA means, if it's like what does a positive ANA means and what it implies, and also a lot to reassure you about a positive ANA that's not a very high titer, for example. So we'll talk about that next week. Tune in, ask the question. I think that was wonderful. Keith, thank you so much for being on with us live, even though it took me forever to figure out the system. And I will see you next week. Bye, everyone.